Thank you for joining us for our pain management presentation today with our partnership with Naval Center for setting up our presentation today. Our presenter today is Jennifer Hutchens, and is a passionate practitioner and scholar in the field of clinical psychology who divides her time between clinical practice, training, and consulting. In her clinical practice, she delivers motivational interviewing, cognitive behavioral therapy, acceptance and commitment therapy, and other evidence-based treatments to adults and adolescent clients with a wide range of emotional, behavioral, and adjustment problems. Dr. Hutchens, part of a multidisciplinary team in the medical office focusing on the holistic treatment of pain management, in addition to being CEO of Hutchens and Associates LLC. In her consulting work, she has provided supervision and training to clinicians and other providers as they acquire skills to deliver service in an ethical and effective manner. Dr. Hutchens is active in state and national government and is a member of the ABA and IPA. She has taught adjunct at Indiana State University in Terre Haute for both the psychology department and the PSYD program. So actually, this is our second clinician that has presented for us. We had a presentation about the Rorschach test last week, so we just kind of continue to learn a little bit more psychology. So thank you so much, Dr. Hutchens, for being our presenter today, and I'm going to turn it over to you.
Thanks. So I apologize about the background. I would be in my office, but I do have puppies that are not being the best role models today. So they are in my office, and I am in here. We're going to talk about the role of psychology in pain management today. It's something that I've been, researching and working with in the last 3 years. It's something that's become more and more of an important topic, particularly with the opioid crisis. And so as we try to find different ways to address pain, because we all have pain, then our psychology becomes a good part of it. If you have any questions or anything, please feel free to use the chat feature or interrupt me. That's fine. I have children, so I'm used to that. And if there's anything that you want me to review, again, please just let me know. Let's get into it. So to talk about psychology in pain, first we have to understand what pain is. So there are at least 100 million adults in the United States that suffer from chronic pain. Chronic pain is, of course, different from acute pain. Chronic pain is when it's lasted, months and months and months longer. And we've all had some kind of chronic pain, I'm sure. It affects more Americans than these three diseases combined: diabetes, heart disease, and cancer, which is absolutely incredible. That we're looking at something that's affecting more than diabetes, heart disease, and cancer. And yet we don't have specialized treatment as researched as we do for those other things. Sorry, I'm working on my screen here. There we go. Pain is useful. Pain is very useful. Pain lets us know when something is wrong. Pain lets us know when we shouldn't put our hands or feet somewhere, right? Or when we need covering, or when something is emotionally hurtful, we feel pain. Chronic pain is complex. Both medical treatments and psychological treatments are important. And most importantly for us to understand at the beginning of this presentation is, I am not going to talk you out of your pain. I have a lot of patients come in and see me and they say, I'm worried my doctor thinks the pain is all in my head. And the first thing I tell them is, your pain is very real. I am not going to talk you out of your pain. If I found that magic conversation, I would patent it and I would buy myself an island, and everybody would visit me, because that's how important, pain is in our lives. It kind of, it runs our lives. So I'm not going to talk you out of your pain. However, there are things that we can do to reduce the pain. So why is psychology important? Well, we're going to do a little exercise here. First, I want everybody to close their eyes and imagine your first heartbreak. You feel that physically. You feel it in your chest, you feel it in your gut, you feel it in your, GI system. You feel that physically, and nothing physically happened to you. You got a broken heart. Our emotions are very painful. So this is why psychology is important. Go ahead and open your eyes. We're going to do another little exercise here. I want everybody to think about something that's hurts right now. So I've got, some knee pain, my back hurts, my hands are hurting, it's cold outside, maybe something that hurts right now. And I want you to say to yourself, I shouldn't be in this much pain. Now, notice what's going on in your body. Your body tenses up. I shouldn't be in this much pain. Your body tenses up. Your chest gets tight. You're taking short breaths. Your shoulders are getting tight right up here. It's not very fun. And so now we're going to say, now I want you to change that. And I want you to say, I'm in pain and it sucks.
Pain and it sucks.
Notice how the body kind of relaxes a little bit, right? Just a little bit. It's just a tiny, minute thing, but the body relaxes a little bit. Words are important. What we say to ourselves is important, and our bodies listens to our words, to our brain. Our body listens to our brain. I will make sense eventually, I promise. So let's break down pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So that's the International Association's definition for pain, okay? An unpleasant sensory and emotional experience. When you stub your toe, you not only have that physical pain, but it becomes an emotional pain, right? You say, ouch, I shouldn't have done that. Why was that there? Why wasn't I looking where I was going? Whatever you say to yourself. Pain is emotional as well as sensory. When we hurt ourselves physically, we feel that emotionally. We feel fear, we feel anger, we feel sadness. We feel it emotionally. And so therefore we have to differentiate between primary pain and secondary pain. Primary pain is that pain that you suffer from physically. Illness, injury, damage to the body or the nervous system. When I'm talking about pain in my neck, I have some mild, narrowing in my neck that's pinching some nerves. And that's my primary pain. Secondary pain is my mind's reaction to primary pain, but often it's far more intense and it's longer lasting. So secondary pain is, oh, I have some narrowing in my neck. Oh my gosh, is my neck going to, break? Do I have a broken neck? How can I can't turn my neck. How can I work like this? How long is this going to be? And all of these emotional questions, anxiety, fear, anger, frustration, sadness, is related to that primary pain, but is called secondary pain. So we look at pain and the conceptual model from acute to chronic pain. And there's pain. The initial psychological distress happens in stage 1. This is a natural emotional reaction to potential or actual physical harm. We have fear, anxiety, worry. We go into stage 2 then after that. So I've broken my ankle. I have now fear, anxiety, worry that leads to depression, anxiety, maybe substance abuse and anger. And it's a long process. But stage 2 is the exacerbation of physical problems. It forms for many different reasons, but it can be based on pre-morbid personality and psychological characteristics. It can be how long you've been in pain. It can be how many doctors you've seen to try to address the pain. It could be if you even got any answers for the pain. And so we look at an increase in depression, anxiety, anger that leads to learned helplessness, symptom magnification because we're focused on it, psychological disorders, physiological disorders, distrust. I hear people talk about white coat syndrome because they've seen too many doctors and they don't trust the doctors anymore. And that leads to mental deconditioning, that acceptance of the sick role, the exemption from normal responsibilities and obligations, and then the consolidation of the psychological behaviors as well. That mental deconditioning and the acceptance of the sick role is when that's, I'm never going to get better. My life is never going to be the same. My body hates me. It's going to be like this forever. There's not going to be any change. I'm never going to feel better. That kind of acceptance of the sick role. We look at prevalence rates of psychological distress in the general population. We see less than we do in chronic pain. This makes sense because when you're in pain, you have feelings about your pain. And so we see a lot of individuals, 30 to 54% of chronic pain patients have major depressive disorder. Current patients with chronic pain, 15 to 28% are currently abusing substances. Lifetime, we see 23 to 41%. There is a difference between dependence, physical dependence, and addiction, which is the substance use disorder. So I don't, I want to make sure that when we're talking about pain medication and the opioid crisis, and just because you take pain medication, and if you have withdrawal symptoms from the pain medication because you've been on it so long, it doesn't necessarily mean that you have a substance use disorder. So I do want to make that clarification. 16 to 28% of individuals suffer from anxiety. And then of course we see the biggest in personality disorders, whether that's borderline personality disorder or antisocial personality disorder, or even depressive personality disorder or avoidant personality disorder, dependent personality disorder. We see those. Compare that to the general population, and we've got a huge magnifying glass that we need to put on psychology with our chronic pain patients. Also, it's important that a lot of these could be premorbid to the chronic pain. They could be there before, including PTSD and trauma, because a lot of times chronic pain is from some trauma to the body, which is also trauma to the mind, car accidents, falling off the roof, getting, we see some wives who have been abused by their husbands physically that have chronic pain problems. And so that trauma comes along with a lot of the pain as well. The cognitive factors of pain is our beliefs about pain. This is going to affect how you deal with pain. Our beliefs about controllability, our own self-efficacy, meaning our, how efficient we feel. Catastrophizing. We notice that a lot of individuals who catastrophize their pain will do worse in pain management with pain with pain treatment. And then your coping skills. Those are the cognitive factors of the pain. Your affective factors, your emotional factors of pain are depression, of course, anxiety, post-traumatic stress disorder, anger, a lot of despair. I've never met anyone yet who has said, I am so happy to be in pain. Not yet. I'm still waiting because I'd like to know what they get from it, right? So just like when we talk about smoking cessation and everything, what is it that you like about the smoking? So what is it that we like about pain? Now, some people will say, I like pain, physical pain, because it gets me out of my emotional pain. And we kind of look at those personality disorders, and that's a whole other treatment. But but it just shows you how powerful also emotional pain can be. We look at, some people say I like physical pain because it makes me feel like I'm alive. Again, I've not met anyone so serious. So I see Mr. Bender is nodding. So.
I do have a quick question that came through on chat, and then.
Oh, it's on chat. Okay, sorry. Let me.
No, and I'll read these to you, so you actually don't.
Okay.
About them. Can a person have chronic pain such as arthritis and those kinds of things, but it be a mild case and not debilitating? I mean, it's constant and it's there, and it's not fun, but it's also not debilitating. You can kind of muscle your way through it.
Oh yeah, absolutely. So of course, arthritis is a great example of chronic pain. It's mild, it's not debilitating, you know, and you still have emotional factors around the chronic pain of arthritis. You know, when your hands hurt and it's harder to do things, or your knees hurt and it's harder to do things, or it's, you know, your body just aches overall and it's harder to do things, we notice emotional factors come in with that depression, that despair. Not necessarily, it could be just regular sadness, but it will affect the chronic pain. Yes, masochists do relish pain. Absolutely. Absolutely. So I was trying not to go there, but we went there anyway. It's all right. I've not met a masochist yet. You know, I tell some of my patients that they're masochists, but because they come to see me, it's a joke. I have really bad jokes, just so you know. Yeah, you cannot be depressed, Betsy. You're right. Betsy said, or you cannot be depressed. It's just life. Absolutely. It is just life. There again, a lot of people suffer from chronic pain that are not necessarily depressed. You know, and a lot of people, this is more surrounding the emotions that can increase your pain. When you look at this chart right here, you can see that you have physical changes. When you're satisfied with your physical function, everything is great. But when there is disruption in daily activities, it can lead to emotional changes. Again, it doesn't have to be full-fledged depression. A lot of people that I see say, well, it's just life. It can lead to sadness. What we do notice is that even if it's not full-fledged depression, there is emotional changes surrounding the way your body feels. It can lead to emotional distress, stress and tension, then change your body. Your pain threshold can exacerbate, it can raise, it can decrease. It can stress and tension can exacerbate the effects of pain. So let me give you an example. Carl talked about arthritis, right? I'm sure a lot of you have arthritis. I have arthritis as well. My husband suffers from arthritis. And yet we're still able to go to work. We're still able to do the things that we need to do. We're still able to walk. We're still able to play with the kids, walk the dogs, things of that nature. And then when it gets super cold and your body hurts and it's a little harder to get out of bed, you think, oh, I don't want to get out of bed today. Everything hurts. Even though it's mild, I don't want to get out of bed and everything hurts. That's an emotional change. You think, but I'm going to get out of bed. This is just life. It's harder to get through the day when you're in pain. That leads to emotional changes. Some of them we don't even notice, but it leads to emotional changes because then it's almost as if we have a pool of resources. And when everything is running on all cylinders, everything is great. But then a little bit gets taken because we have to deal with the pain in our body. And so now we have less resources here to deal with the rest of the day. So I might be a little more irritable, might be a little more quiet. It can lead to emotional distress. I might be a little less patient. Things might get to me a little more because My cognitive resources have then been delineated to deal with my chronic pain, even if it is arthritis. One example I like to use is think about if you have grandchildren, when you're playing with your grandchildren. When you feel good, everything is fine. When you're hurting just a little bit, their 20 questions can get a little bit annoying. The same question over and over. So that causes stress and tension, and then it can go right back to physical changes. And so it becomes this circular pattern. I'm moving forward here. I thought I was moving forward. There we go. Other thing that depends on how you experience pain is also kind of your predispositions. So a lot of you may be dealing with your arthritis, your knee pain, your back pain, your arm pain, wrist pain, shoulder pain, migraines, headaches, just fine. And many may not be dealing with it just fine. We have to look at genetic predispositions. We have to look at biological vulnerabilities. So, depending on any co-occurring disorders or co-occurring illnesses, that's going to make a difference on how you experience pain. Your psychological vulnerabilities. If you've already got depression, anxiety, or a predisposition for depression and anxiety, you're going to experience pain in a different way than somebody who does not have those predispositions. Social vulnerabilities as well. Health disparities, your culture, stability, SES. Do you have friends? Are you lonely? That's going to make a difference on how you experience pain. The more of these predispositions you have, the more intense the pain is going to be. And so we look at how unbalanced it can be and then work toward balance. Because again, pain is bio, psycho, and social. We know that even though you're in pain, if you are surrounded by people because we are social creatures, you will experience it in a much different way than individuals who live by themselves, are lonely, or have no friends and family or social aspects. Even worse in the pandemic, when we have to isolate ourselves and quarantine and things of that nature, we have seen an increase in pain because of the lack of social engagement with individuals. Your brain will tell your body how to experience life, and your body will listen to your brain. So what does it mean? Well, it means as pain becomes more chronic in nature, psychological variables play a part. It's not pally, it's play. I should proofread. This is an increasingly important role in the maintenance of pain behavior and suffering. Psychopathology is a significant part of chronic pain. Again, individuals who may not have ever seen a therapist in their life or had any type of mood disorder will experience pain in a much less intense way than individuals who have those psychological predispositions. One of the nurse practitioners I work with, Dax Duncan, has said that, has described my job as getting his 25% worse patients. So, which is not accurate. I have really great patients, but these are individuals whose emotional pain is playing a huge role in their physical pain. The biopsychosocial model has been proven to be the most heuristic approach to better understand the complex interaction among biological, psychological, and social factors that contribute to the pain. And interdisciplinary pain programs, therapeutic pain programs, have been developed like the one that we offer here, and they've been cost effective. Now, that being said, we still live in a medical model world. So, for example, if I have a patient come in, and this has happened, I have a patient come in and we work on their depression, their sadness, their marital difficulties, their anxiety, their low self-esteem, whatever is presenting. And they start to get better and they start to get better and more stable, and their fibromyalgia starts to improve and starts to improve. Then at that point, what usually happens is my patients come to me and say, man, this medicine is finally working. So even though we have interdisciplinary pain programs, the doctors usually get all the credit anyway. So so then we come to, well, why do I have to talk about it? And I've said probably 4 or 5 times, your brain tells your body what to do. Your body listens to your brain. So remember in the beginning where I said, I shouldn't be in this much pain. I shouldn't be in this much pain. I shouldn't be in this much pain. And then we switched it. The body got tense. We switched it to, I'm in pain and it sucks. I'm in pain and it's not fun, if you want to use some other things. The changes that I'm hoping you found in your body were small, but they were different. When we say I shouldn't be in this much pain, I shouldn't have to deal with this, my body hates me, I shouldn't have fallen down, I should have watched where I was going, I shouldn't have to deal with my arthritis, I shouldn't live in a cold environment, I shouldn't, all of this stuff. Your body is going into defense mode. Your brain is essentially telling your body something's wrong, and now I have to go in fight or flight. The problem is when it's chronic pain, there's nothing to fight. So sorry, Carl, I could see you talking, but I couldn't hear you. Oh, okay. So when we say I shouldn't be in this much pain, our body goes into defense mode. When we go into fight or flight, our sympathetic nervous system takes over. Our pupils dilate, our pulse. Sorry, one of the children just came into the room. I got distracted. Thanks for being patient with me, guys. The pulse increases, your pupils dilate, your body tenses up because it's getting ready to be in fight or flight. It's getting ready to, it perceives a threat. Your brain has said, there's a threat in my body and it should not be there. And there's no threat that you can deal with. So we move to what we call radical acceptance. Acceptance does not mean that I have to like the situation. Acceptance does not mean approval. Acceptance means I've stopped fighting the reality of the situation. Just that acceptance of my body in pain allows my body to relax a little bit. I have arthritis and it's not fun. Okay. My body is then saying, I don't have to fight anything. This is what's going on. I can relax. You should have noticed that you were able to take deeper breaths. Your shoulders fell a little bit. Your brain kind of got less chaotic, the way I like to say it, because when we say should, I shouldn't, the brain gets kind of fuzzy and chaotic. It's a good way to, we start thinking and we start trying to fight a threat. However, when we accept it, again, acceptance does not mean approval. When we accept what is happening in our body, then our brain can kind of calm and then move on. We have different treatment approaches and methods. Motivational interviewing, of course, cognitive behavioral therapy, acceptance and commitment therapy, exposure therapy, group therapy. We're going to go into all of these. I'm not going to discuss today, but this is also effective. Biofeedback training, and also hypnosis. I do hypnosis with my patients at times, not usually when I have to talk or when I'm coming off of a sinus infection, because I do have to talk nonstop for 30 minutes. Looks like we got a new chat here. Acupuncture, you're right, absolutely. Acupuncture helps. Massage therapy helps as well. These are the psychological approaches that we can take, but hypnosis is very effective in treating pain, as biofeedback is as well. So the 5 principles of motivational interviewing. Motivational interviewing came from individuals who wanted to figure out why people weren't getting better. And the problem is we were trying to throw treatment on individuals rather than allowing them to steer the treatment. And so when they would get defensive, well, challenge this, challenge that. Well, that's not kind of working out. So it started with substance abuse, but we have motivational interviewing for a lot of other things. It's essentially meeting somebody where they're at in their stage of change. The 5 principles of motivational interviewing include expressing empathy, developing discrepancy, avoiding argumentation, rolling with resistance, and supporting self-efficacy. And so we kind of do all of these things in a way to help individuals. And you can see some of these questions right here are some of the ones that we would use for pain problems. What's gotten better or worse in the last 6 months with your pain? You know, when I talked earlier about smoking cessation, it was, what do you like about smoking? What is it that smoking does for you? When we look at pain, what is it how is it that the pain serves you? Is there any benefit to the pain? Usually I get the answer no, and that's okay. What are you doing now to cope with your pain problem? Is it working? And so we use these to recognize what the problem is. What do you miss most about your life before the pain began? What concerns you the most? We have to address all of these things, and very directly, because if I don't start talking about your fears, whether it's pain, whether it's about pain or anything else, if we don't start talking about what you're afraid of, it's going to get pent up, and then it's going to be like a pressure cooker that doesn't steam, and you end up with green beans all over the ceiling. So we have to talk about what the concern is, because again, when you're holding in all of that concern, it is also exacerbating your pain because it is causing internal stress that you may not realize. Stress inflames all your organs and your joints. And so at that point, you're just in more physical pain. It's just, like I said, revolving door. How would you like life to be different? If you received treatment, how would you know it was working? So that's usually, well, I'll be out of pain. And then we want to evoke optimism, right? Because it's very easy to fall down the rabbit hole of negativity. And so we also want to talk about what's going well. What area in your life has not been touched by the pain problem? What evidence do you have that you can succeed? Why is your pain at an 8 and not a 10, right? Looking at it that way. If you're rating it as a 6, why is it not at an 8? Well, because I'm not hurting here, here, and here. And you can look at kind of differences in where things are going right. And that's important. What aspects of your life do you feel the most control over? You know, what's going to make things, or engaging in therapy, or engaging in exercise, or engaging in yoga easier for you? A lot of times we have mental barriers to a lot of treatments that might be available simply because it's this intrinsic belief that we don't think that we can do it while we're in pain. Moving on. Cognitive behavioral therapy. You'll hear a lot of doctors talk about CBT. CBT is the oldest, one of the oldest, not the oldest. Psychodynamic theory is the oldest theory, but CBT is kind of the oldest evidence-based practice that has been manualized. It is problem-oriented. It is the most researched. It's educational. It teaches self-management, problem-solving, coping, communication skills. It is collaborative. There is homework It makes it use of the skills both in session and out of session. And a lot of times I tell my patients, look, this is for you guys to do, because 1 hour every week or every 2 weeks with me is not going to do the magic trick, right? So a lot of what we talk about in the office has to be done at home. It addresses the relationship among thoughts, feelings, behavior, and physiology. We have certain feelings and thoughts about our pain. We have a relationship with our pain. It's not always one that's very functional, but it is almost like we're living with a whole other aspect and person. You know, you'd be surprised how much you talk to your body when you don't even realize it. And that's, you know, and you have a relationship with your pain. You can anticipate setbacks, lapses in CBT. That's okay. One of my taglines is 3 steps forward, 2 steps back is still 1 step forward. So we don't worry too much about setbacks. I'm not going to read all the goals of CBT there. I know you guys will get these PowerPoints, and that's great if you don't already have them. These are the goals of CBT, and we're looking at combating demoralization, enhancing self-esteem, showing, you know, individuals that you can do this. So we talk about behavioral activation. Is it important that I get up every day and take a shower? It is important that you take a shower every other day. Hygiene, your hygiene will affect how you feel and will affect how you feel about your pain. So is it important for me to do all of these things? Yes, it is, because we want to foster self-efficacy. We want to break up automatic maladaptive patterns. We want to teach skills training. So relaxation training, guided imagery, that comes with cognitive behavioral therapy. And then, you know, we want to learn how to anticipate the problems to go through relapse prevention, because you can get to a place where your pain is stable, where you're functioning well, and then all of a sudden start to wonder what's going to happen if I ever go back, because that's what always happens, right? We're always waiting for the other shoe to drop. And so part of CBT is to anticipate the problems as well as ways to deal with them. Acceptance and commitment therapy is kind of what we started on earlier. I use a lot of this in practice. There is a lot of research on acceptance and commitment therapy. It is called ACT, not ACT. The basic premise is if we accept our pain, we can limit its control. The minute I stop accepting that I'm in pain is the minute that I stop controlling my pain. Once I go to the I shouldn'ts, then pain has won, because I am dealing with something that is an imaginary reality. The reality is what the reality is. Again, acceptance doesn't mean approval. Acceptance means we've stopped fighting the reality. So ACT helps us change expectations from the elimination of pain, because again, I can't talk you out of your pain, to living as well as possible with pain. I've had patients imagine their pain as colors, people, describe them, give it a name, to exert more control over it, to become external. So a lot of times we want to imagine that this pain is external, and that because that aids us in controlling it with some tangibility. We're also going to look at your personal values and your goals, and how your behavior and thoughts and emotions work within those personal values and your goals and toward your goals. And so we want to, you know, look at how you are in contact with the present moment. What are your values? What are the committed actions? What is yourself as context? Cognitive diffusion and acceptance. We want to detect, know a thought is feeling or feeling is present, register the content, understand the message of the experience, take it as true, and then use the experience. What happens with pain with ACT is actually incredible, and we have to make sure that we're psychologically flexible. So it takes a minute to get there, and that comes with motivational interviewing. But once that acceptance comes in, it's amazing how much control you end up having over how you experience your pain. So we do a lot of that. Exposure therapy, a lot of times people will avoid. I always use the Chinese finger trap. You guys remember the Chinese finger traps? Where you kind of stick your fingers in there, and then what's the first thing you want to do? Pull, right? How do I get out of this? That is a great metaphor for anxiety. We want to approach whatever it is that we're afraid of, because if we avoid it, then the fear gets worse. I have a fear of spiders. I'm not afraid to admit it. It's fine. I'm not afraid to admit it. I've dealt with it, guys. It's okay. I've dealt with it. The more I avoid spiders, the more fearful I'm going to be over spiders. So when I was in grad school, we had a pet spider, pet tarantula. It wasn't mine, but it was a pet tarantula. And they said, well, Jen, you're going to be our guinea pig. We're going to use you for exposure therapy. We'll introduce this a little bit at a time. And then finally, by the end of the week, you'll be able to have the tarantula crawling up your arm. And I said, I'm not your girl. Count me out. Not me. But that's what exposure therapy is. First, you're in you're in the same room with it. You'll approach it. You get used to it, and we use calming skills as we're going through this because of the panic. The fear avoidance model of pain is that we have a fear of pain. If I do this, it will hurt, right? So don't do that. Well, that's all well and good until it's physical therapy and it's for things that have to get better. So you have an injury, you have a strain, you have that pain experience. If you're not afraid, and like, one of our audience members said, you just deal with it, there's low fear, then it's more likely that you will experience recovery from that. However, if you catastrophize, oh no, I'm never going to get better. Oh no, my life is over. Oh no, it's never going to be, oh no. Then there's fear of movement, there's fear of re-injury, there's fear of the pain. Hypervigilance becomes, you become hypervigilant over everything that you do. You do avoid it, escape, can go back into the pain experience. And so you can see how, with that little chart, how we experience pain makes a difference. When we talk about exposure therapy for that, then we work toward feeling the pain, acceptance of the pain. We work toward walking. And again, that's kind of what physical therapy does. When you have a knee replacement, they send you to physical therapy. You might be afraid to walk on the knee because it hurts, but they want you to walk on the knee because it's better for you. And so how you, again, experience the pain makes a difference. If you're catastrophizing and saying, no, I can't walk on my knee, it's going to hurt, I'm never going to get better, then at that point, you can see it goes into all of that stuff versus the low fear of acceptance of the pain, knowing that it's temporary, and moving forward. Does that all make sense? Did I lose you guys on that? I'm hoping it makes sense. Sometimes webinars are a little different because, well.
No, I think it made total sense. And I'm looking at the few faces I can see and they seem to be good. So
perfect. So with exposure therapy, we do a hierarchy of your feared activities. That's always fun. What do you fear the most? So what is it that you're afraid of the most? There is an explanation of a treatment of the treatment approach. We do teach relaxation techniques. I'm not going to expose you to something that's anxiety provoking without teaching you how to relax and breathe. We look at what your expectations are. We look at if they're realistic expectations. If you say, Jen, I want to be pain-free in a week, and it's something that you've been experiencing for the last 30 years because you have arthritis, it's probably not a realistic expectation. But if you say, I want my hands to hurt less this week, how can we get there? Then we're going to talk about different ways to view the pain, also what to do, you know, paraffin wax packs, other holistic measures. Excuse me. It's not the COVID, it's sinus infection. We're going to normalize pain during the activity, because that's the other thing. You know, somebody said you learn to live with it. Absolutely, you learn to live with it. You can normalize the pain and make it less fearful. And when you do that, then it becomes better able to control. There has to be confidence in the practitioner that you're working with. If you don't trust me, we can't do exposure therapy. You're not going to do it. And so there has to be a basis of trust there and confidence. We're going to monitor the expectations and changes in the expectations, as well as changes in the emotional state. Make sure everything is safe. You see, I put safety on there several times, and then repeat it. Group therapy is important. And it's something that we haven't been able to offer as a clinic yet, but I'm looking forward to offering it this spring. And there are 4 major goals with group therapy: teaching pain coping skills, educating patients about their pain, providing, not proving, it's supposed to be providing, proving social support. We've got it, it's proofed. Providing social support and teaching mindfulness and acceptance-based strategies. Pain can be very lonely. When you're suffering in pain, it can be very lonely because you're the only one experiencing it. Similar to, you know, a death in the family, you're the only one who is experiencing that. There is grief that comes along with pain. The loss of abilities, the loss of being able to do things as well as you used to be able to do makes a big difference. And so you end up grieving that, even if it's little by little. Because pain can be so lonely, it's important that we understand why group therapy is important. I might be in your group, and I might not know what you're going through, but I do know that I'm in pain too, and we can relate on that level. And maybe some things that I'm doing will help you, and some things that you're doing will help me. It also allows us to kind of talk about how we experience pain differently. I don't like it when people say all group therapy is you know, just a complaint session. We have to talk about the problem to talk about the solution. But we can't just focus on the problem. There also has to be talking about the solution. And so a specific goal is important for the basic format and structure of the group. So are we going to talk about pain coping skills, or is this more just focused on fibromyalgia, or is this a pain group talking about, you know, failed back surgeries or failed back syndrome? You know, do these individuals have an intrathecal pain pump, and do we need a group for the intrathecal pain pump, you know, in case there's problems with that? And so it's really important that we have a specific goal, so it does not become this kind of free-for-all group. We also have to make sure that, you know, if I've got a group of fibromyalgia patients, they are vastly different than the group of lumbar spine patients, and experiencing that pain kind of differently. And so that makes a difference. And then, of course, the level of training required by the group therapist. We don't want somebody who isn't trained in pain and psychology and the psychology of pain doing a pain coping skills group. We want you to be safe. We don't want somebody who's not trained in hypnosis doing a group hypnosis, right? We don't, I mean, it doesn't turn out well, I'm told. So we've got patient education. We do have a social support group, that we're looking at starting. Coping skills training group that we're looking at starting. Group therapy is short term, 8 to 10 weeks, and not everyone is appropriate in group. The most people that are appropriate for group are those that their pain is likely to persist. So if you're still looking for that magic conversation, that magic pill, that magic treatment, then group therapy may not be appropriate for you. Additionally, individuals who are only focused on pain medication are not necessarily going to be appropriate for group. You have to be open to learn new pain management skills that are maybe not so medically focused. So I'm not going to give you a walker, but we might do some stretches, I'm not going to, give you a cane, or we don't pass out Norcos in group therapy. It's not a Norco party. I realize my jokes are terrible, guys. It's okay. I've accepted it. Does it work? Absolutely, it works. That's an example of bad therapy. Research consistently shows that psychological treatment for pain management absolutely works. I don't know if anybody's ever gotten an EMG before, but those are some of the worst. That's one of the worst tests I've ever had in my life. If you don't know what an EMG is, it is where you go to the neurologist and they stick you with a bunch of needles wherever they're trying to see where the nerve damage is, and then having you bend your muscles and it hurts. So this needle goes, let's say it's in the hand, this needle goes directly right in here, and then they have you bend your thumb like this, and they measure something, I'm not a real doctor, so I don't know what they do, but it measures something. It's painful. It's very painful. A lot of people have a problem with the EMG. What you can do, though, to get through it is relaxation techniques, guided imagery techniques, things of that nature. So, that's when that happens, you don't have to make a sound, and it helps you get through that acute pain. It also, research shows that the psychological treatments and how we feel about our pain, isn't that funny to say, how we feel about our pain, what we think about our pain, how we react to our pain, can change and make a difference to where the pain is not so intense. Even just kind of a cathartic venting with psychological treatment. Think about when you have a good cry. Your body is more relaxed and it's in less pain. Reduction of psychological symptoms resulted in pain reduction. And there's good evidence for this. This is why IU is going this way, and there's many holistic and integrative treatment centers that are opening up, because we've got research and evidence to show that psychological treatments are efficacious and effective. Future research should refine the formulation of the pain and then also attempt to make explicit links between the process of therapy and outcomes. That's what we're looking for. But how we feel about our pain makes a difference. So that's the PowerPoint. What questions do you all have for me? I went through that faster than I meant to, sorry.
Okay, Carl, I know you've got questions because I've watched your face through this whole presentation. And yes, I did hear that, his idea was to drink for the test that you were just talking about. That was so painful. I don't think that's helpful right now.
Well, they might kick you out of the room. I mean.
So I have a couple of questions, as everybody else. Everybody else, just go ahead and unmute if you want to ask questions. Because I can think of it from two different perspectives. I can think of it as, okay, I can see how this would be very, very helpful in people who become addicted to painkillers,
Mhm.
and getting them off of that drug addiction and that kind of thing, because they do become addicted to the drug, but it's because of the pain, and then there's psychological issues. So I get all of that. I also think that this is probably pretty good for what we were already talking about as far as like arthritis, lupus, or anybody who has some sort of, whether it's full pain or whether it's maybe, a change in their body that has now become a little bit debilitating. My dad has a congestive heart failure, so he can't walk very far without losing his breath. So he has kind of gone through a lot of what you've talked about. It's not so much of a drug issue, because it's the acceptance of this is what I can do and this is what I can't do, and learning to live in the new reality.
Mhm.
So I think that all of these things play a big part, in completely and totally different situations.
Yeah, absolutely. So, the first, let me address the first part where you talked about addiction. Sorry, I'm trying to get to where I can see everybody, and I don't know why I can't see everybody. Anyway. So about 45% of all overdoses from opioids are individuals who started in a pain management clinic. Now, for a while, and I've got a whole separate opioid presentation on how the opioid crisis, came about and rose. And for a while, our doctors and the big pharma, pardon me, but big pharma kind of put us to the test we're just malpracticing all over. They just, and I'm trying to be I'm trying to be very political at this point. I mean, essentially they screwed us, right? Pardon the language, but they screwed us. The doctors were writing prescriptions without ever seeing patients. Of course, there's documentary on this. And it was just, oh, you're in pain here, you're in pain here, you're in pain here. Overprescribing. They were overprescribing. And so addiction, then comes with that. The more your body will become dependent on it. Now, what's the difference between addiction and dependence? I'm dependent on some medication. I have hypothyroidism. I have to take thyroid medicine. We also notice that we have physical dependence on things such as antidepressants, on other medications. You have to wean off of them as they come down. It doesn't necessarily mean that you're going to have a psychological urge to use them. So let's say I have a predisposition for addiction. I've never touched anything, or I have a predisposition for addiction, physically, emotionally, socially, mentally, whatever. Let's say I don't have a predisposition for addiction and I just like to feel good, and I break my ankle. I go to the doctor and the doctor prescribes me some pain medication. They do surgery on my ankle, prescribes me pain medication. It says, take one of these every 8 hours. Well, all right, fine. That'll make me feel okay, but I don't want to feel okay. I want to feel good. So rather than taking one every 8 hours, I take one every 4, or maybe I double up on them. The brain is going to then react to that. The brain's going to say, oh, whoa, we're making too much of this, because it hits your opioid receptors, right? So it hits the receptors and the brain says, I'm making too much of this, and it'll scale it back. Well, at that point, then now 2 pills make me feel okay, and I don't want to feel okay. I want to feel good. So maybe I take 2 more. And it's this constant back and forth tennis game, essentially, between the brain of the synthetic drugs and the brain with natural opioids, to where eventually when you're coming down and we see people come in and say, oh, I ran out of my meds too soon. Oh, I ran out of, this, that, and the other. Why? Well, I was in pain. I had teeth pain. I was in pain. It was too much pain, And so I needed to take more. Well, at that point, then your body has become addicted to it, not necessarily dependent, because there's a craving, there's an alternative reason for use. And so we have to look at it that way. We see some of that, and that's why it's important that every doctor, and I'm going to get on this as much as I can, every doctor needs to get an X waiver, because it makes your job a little easier. If you have somebody who is addicted to pain medication but still in pain, then at that point we have to look at alternative pain medications such as Suboxone, where it can be safely prescribed, where it's not just, you know, about the pain, but it's now about an opioid use disorder. Psychology does play a role in that, absolutely. Psychology plays a role in how to overcome the triggers, how to overcome the cravings, how to get through those physical withdrawals, but also the emotional withdrawals. When we talk about, you know, Michelle, you mentioned your dad has congestive heart failure and has gone through a lot of, this is how far I can walk, things of that nature. We also have to look at kind of the little things that we say to ourselves. So even when he's going, oh, I just can't walk that far, that emotion that comes with that devastation does something to the body, you know. And so it is very, very emotional. Our emotions play a role in almost everything that we do, and our body physically reacts to that. I hope I answered your question.
Well, you did, and I think that it's one of those things of.
Jen, I have a question.
Yes, ma'am.
A company is coming to Terre Haute for treating those who have an addiction, and it's a 28-day program. So listening to all of this, and I'm wondering just how effective those programs are for those individuals. Can you?
So 28-day program, you know, it cracks me up because of the 28 days. The insurance decided for us how long it would take us to get someone sober. And the insurance decided it was 28 days. And that was a long time ago. The 28-day program is essentially designed to give them a start, take them out of their current environment, place them in a stable, you know, environment there, teach them skills, and then place them back in their current environment. 28-day houses have a high recidivism rate simply because of the lack of aftercare and follow-up. For the individuals that are addicted to pain medication, it depends on how far their addiction has gone. If it's something where they cannot be controlled, if they can't control it themselves, if they have, you know, problems with trying to hide things of that nature, then at that point, the 28-day program would be effective. The problem with the 28-day program is that we also need to make sure that they have the medical capacity to also treat the physical pain and the withdrawal, the detox, because detoxing from opioids will not kill you, but a lot of people say that it feels like they're going to die. So the effectiveness of the 28-day program essentially lies on their treatment within that 28-day program, because we see some that are really, really good, and we see some that are not, you know. So the effective treatment in there, also the amount of peers that they have is going to make a difference. Their medical side makes a difference, and also their beliefs in whether or not they do have an addiction.
Mm-hmm.
Right? If I don't think I have an addiction, you can court order me, or the doctor can send me to a 28-day program all you want. Guess what's going to happen when I come out?
Yeah, same thing.
Yeah. And so the individual beliefs on their own disease, their own pain, play a huge role in how effective those 28-day programs can be.
But if you have a facility and there are 35 women in that facility, do they all need to have the same kind of addiction problem?
Not necessarily.
Okay, all right. So
not necessarily, okay. Because, you know, addiction is, I always tell my patients, relapse happens way before you ever use a drug.
Okay.
Addiction is your beliefs about you know, whatever it is. And everybody has a drug of choice. You know, your drug of choice might be heroin, when Michelle's drug of choice might be meth, but you guys are both going to use for the same reason, and that's escape.
Okay, thank you. Thank you.
That's why there's a lot of individuals that are really upset about medication assisted treatment, because they're from the old school of you have to do it cold turkey, or you're, you know, it's not replacing a drug for a drug. You know, it's teaching them how to stabilize the brain while learning coping skills. Pushing through pain can be dangerous. Yes, absolutely. Carl asked, does that mean pushing through the pain can be dangerous? Absolutely. It depends on the type of pain. If it's a new pain, yes. If it's your arthritis, then, I mean, and you're used to it and you're used to living with it and this, that, and the other, it's not as dangerous. It's more of an acceptance. I look at it that way rather than kind of pushing through the pain. If you have medication to help you, then absolutely do use the medication. I had somebody tell me yesterday that they didn't realize that an anti-inflammatory would do wonders for their body. And so that's, and they were just so excited, you know, by all means, yes. Take the medication. Don't push through it. Use your coping skills, because pain is inevitable, but suffering is optional.
Okay, other questions? Comments? I'm looking. Go ahead, Sam. No, okay. Eileen, you have any other questions?
No, thank you.
Okay. Phil and David, I can see you. Okay.
This has been excellent. Thank you very much.
Oh, good, good. I feel like I kind of jumbled and back and forth. So, you know, the kids coming in, the dogs barking downstairs.
No, it was great, and you covered a lot of information, and you covered it in a lot of different ways. So, like you know, we talked about the addiction side as well as you know, just generalized pain, and I think it makes you understand mental attitude towards your pain is a very big part of your pain. I think that's something that everybody needs to learn, no matter what their physical pain is.
A pain that some people overlook is the neuralgia after having shingles.
Mm-hmm. Oh, yeah. And that, I mean, that is pure suffering for those individuals. Yeah. Because that's just, that nerve pain is, from what I understand, feels like your entire body is on fire.
Yeah.
One of the things
Acupuncture helped me with that. Acupuncture did.
Acupuncture did? Excellent. Yes. Excellent. Yeah. One thing I do want to show you guys, let me see if I can get out of this screen. Don't mind all my tabs open. YouTube has.
You will probably need to stop sharing and then reshare to get it to pull the YouTube screen.
You think so?
That's how it's been acting lately. Sometimes it works, sometimes it doesn't. But if it doesn't pull automatically, because I'm not seeing your YouTube or anything.
Okay, hang on. Stop share.
There you go.
Okay, now share your screen again and click on the YouTube.
Yeah, easy for you to say.
I only do these like 6 times a week, so yeah, I've gotten used to the weird part of Zoom.
I see what it's doing. Yeah. Okay. Can you see it now?
If there is sound to it at the very bottom of your share screen, make sure you click the share sound button. Yeah.
Guided imagery for pain relief.
So YouTube has a bunch of free guided imagery for pain relaxation. YouTube has guided imagery for everything, first of all, but with the pain ones, it is really incredible the results that we see with guided meditation. I will have individuals come into my office with a pain at an 8 and leave at a 5.
Wow.
Doing a guided meditation. And so a lot of times I will assign these to individuals to do. The one I like the most is this one. It's 25 minutes, the Heal Your Body. He is Australian, so it's important that, you know, you find a guided meditation with a voice that you like.
I can see that.
Because if you're listening to something that you can't stand their voice, then it's not going to work. It's just going to irritate you, which then is going to increase your pain. So yeah, the guided meditation works really, really well. Neuropathy is also difficult. Absolutely. Neuropathy, neuropathy is just, you know, I have patients that just say, I don't know. And again, on fire, but they feel like their legs, their arms, everything is on fire, or it just goes numb, but it's not that good numb feeling. It's that heavy, tingling, you know, where you just want to kind of cut your leg off feeling. Maybe not that death. That's catastrophizing, guys. That's an example of catastrophizing. But these guided meditations, these guided imageries really work. They really help reduce the pain. So a lot of times I'll say, if you have trouble getting up in the morning because you're stiff, you know, and you have your YouTube on your phone available or on the computer, play one of those, go through one of those and relax your body before you get out of bed, because it allows you to listen to the words. It's different than regular meditation where your thoughts can kind of go this way. And you can then stress yourself out because your thoughts are stressing you out. With the guided meditation, you've got somebody, even if your thoughts go this way, bringing you back here, you know, bringing you back here, focusing more on the breath and things like that. Highly recommend that.
That's great. And I love we've done a couple of mindful things with like Dr. Jean Christeller.
Mm-hmm.
And we've also done some meditation, and those have all been great.
Bring out the bowls.
You know, she actually did bring out the bowl once. She did use the bowl once that I can remember, but it's one of those things from my own personal experience. It takes practice. You can't just learn to meditate in like 2 minutes.
No.
You have to practice actually meditating before you can meditate. So.
Yeah. And there are a lot of people who, you know, if I like to do it in the office because then you can see the results immediately. You know, if I were to tell you, hey, go home and play YouTube and you'll be in less pain, you're going to look at me like I'm crazy and say I'm in the wrong job, you know, but it actually, so that's why I try to actually do it in the office with them. And, you know, yoga helps also with chronic pain. I have an individual who has really bad neuropathy and she loves her gentle chair yoga. Just to kind of help with that pain and movement of the body. So any kind of chair yoga, please be safe. Any type of holistic meditation. What other questions you have?
Okay. Any other questions from anybody else? I'm not seeing anything from anybody else. But thank you so much. This was fantastic. I will send this video out to everybody once I get it processed and edited down. If you've got additional questions, let me know, and I will be happy to pass those along. I would love for you to do something because, in all honesty, you got me thinking in a whole new way of doing some programming kind of thing. So I always love when that happens because I'm now thinking, okay, because we've done series on the homeless, And a big part of some of the homeless thing is one, addiction. That's a big
Mhm.
part of it. You know, and just kind of those kinds of things. So yeah, now I'm thinking of some other stuff, but I did have to laugh as you were talking about the, I'm trying to think of what you called it. It's basically where you kind of face your fears.
Yeah. Oh, the Chinese finger trap.
The Chinese finger trap I got, but it was more of the spider.
Oh yeah.
Yeah, no.
That was. I had a great cohort. I really did.
Yeah,
We like to play friends.
I am with you, and I have accepted my fears of certain things, and I'm perfectly fine with just fearing them, and I'm all right with that. So I have no interest in following through on that therapy to
Yeah. I've gotten
alleviate
to the
that.
point now where I look at the spiders and I'll say, you can live if you live over there.
Yep.
I know you have a purpose, but live over there. You know.
Absolutely.
The other thing is if people offer you hypnosis, clinical hypnosis, don't be afraid of it. I know a lot of people are afraid of it. It's not what you see in the movies or on a show, you know. When I first got trained in hypnosis, and this is not my hypnosis voice, I couldn't imagine trying to go under with this, listening to this voice, but it's much softer, it's much calmer, it's much more relaxing. But when I first got trained and conducted my first hypnosis session, I went and talked to the nurses after I was done, and they said, oh, I want to lose weight and I need to stop smoking and I don't want you to make me cluck like a chicken. And I said, look, y'all, you know, by the time I'm done with you, you'll be skinny, non-smoking chickens. You know? But it's not that way. Hypnosis is essentially focused concentration. It allows you, I said I wasn't going to cover it, but here I am. It allows you, it's kind of like when you focus on the TV and everything else kind of goes away. It's this hyper focused concentration, and you will not absorb a suggestion that you don't want to. And so, you know, if your motivation is to cluck like a chicken, then you'll absorb that suggestion. If your motivation is, you know, not to cluck like a chicken, you'll just ignore it. Your subconscious will ignore it. So it's really kind of a fun and unique tool to use. And we do record it, and then I send it home with them. So yeah.
That's great. Well, another tool that people can use for coping with all of that. Thank you so much. Thank you everybody for participating today.